2, 1. Please start.
Hello, good evening and namaskar everyone. It's a pleasure to welcome you all for this exciting discussion on optimizing treatment outcomes in lung cancer. It's a great pleasure to welcome and invite the program convener, Dr. Suman Gupta sir. Everyone knows him. He doesn't require any introduction. Senior consultant head, medical oncology, hematology, and bone marrow transplant, director for Metro Cancer Institute, Faridabad. So once again, a very warm welcome. Good evening to everyone. Dr. Suman sir, over to you for setting a context, please.
Good evening. I welcome everyone who has given his precious time for this meeting. Shyam sir, Shubham, and everyone who has been there. I must, on the onset, congratulate the Horizon team that they have made such a good faculty list and such a good sessions in this program. So, without wasting any other time, let us start the meeting. And I'm all excited to hear Shyam sir, who will be our opening batsman and, as usual, our mentor for everything. Welcome, Dr. Shyam sir. Thank you for joining.
So we have the first speaker, Dr. Shyam Agarwal sir, Chairman and Head of the Department for Department of Medical Oncology at the prestigious Sir Gangaram Hospital, Delhi. So good evening to you, sir. Over to you for this interesting topic. Over to you, sir. The slides will be played by us.
So thank you, Sumant, and thanks to Horizon for organizing this meeting and giving us this opportunity to come on the platform to discuss a common topic on next generation sequencing in non-small cell lung cancer. So I think, as we all understand, non-small cell lung cancer has become the poster boy for biomarker evaluation in the last couple of decades. And an orphan disease in 1970s, 1990s rather, I would say, has now become a very, very sought after, heterogeneous disease, in the sense that you do have several targets which can be identified, and we need to understand as to how we should be, doing that. Although over the years, as we know, you need to differentiate between squamous and non-squamous by looking at TTF1 and P63 or P40. So once you have that done, then there is a need to look for these common or uncommon, aberrations in the gene, and the EGFR, ALK, and ROS, of course, lead the pack, followed by BRAF and NTRK, RET, MET, exon 14, and many others, as you will see in the subsequent slides. So this has become mandatory to look at in the non-squamous, and also in the squamous, and I'll show you a few slides there, especially if somebody is young, never smoker, or a light smoker, or if the biopsy is small and it's of mixed histology. So some people, go for EGFR and ALK in two different tests. For example, EGFR by PCR and ALK by IHC. And then the rest of the, genes can be looked at by a broad NGS. So which is, is critical today before we proceed with any kind of treatment. And then, of course, we need to look at the PD-L1 expression in all non-small cell lung cancers. So why did we do EGFR and ALK first is because these are common, number one. Number two, and the turnaround time, if you do EGFR and ALK, would be less than 3 days, and one can initiate treatment. Because if you order for NGS for all of them, then the turnaround time would be at least 10 to 15 days. But the problem is that sometimes the tissue is so small, you can't split it for IHC and for PCR and then NGS for the rest of the genes. Therefore, a lot of physicians tend to order NGS and wait for 10 to 15 days for these tests to come, and then take a call on the treatment if the patient is stable. If the patient is sick, well, then one can initiate chemo, depending upon the type of malignancy. And of course, we should withhold the immune checkpoint inhibitors until we have the availability of NGS report or EGFR and ALK negativity. So I think this is, in a nutshell. Next slide. So now coming to a little more details of this. So, you can do the genomics, that is the DNA analysis by NGS. And there are two techniques which are readily available. One is the, hot spot mutation analysis, and the second is comprehensive genomic profiling, because one can look at point mutations or deletions or copy number variations and structural variations much more effectively in comprehensive genomic profiling, because it covers the entire exon. Whereas the NGS, which we routinely do, is only looking at some hotspots. So therefore, but CGP is more expensive, and therefore, you need to weigh that as compared to the hotspot mutation. Now, coming to the RNA sequencing, which is again important, especially for gene fusions, and I'll show you more slides into that effect, are required because a lot of these gene aberrations are actually fusions or, splice site variations, etc. We're not focusing on epigenomics. I'll show you a few slides, methylation, histone modification, but that is only meant for early cancer detection. So basically, we are focusing on DNA and RNA. Next slide. So this is how it has evolved over the years, that optimizing fusion detection by incorporating RNA into diagnostic panels has become important. We started with single gene testing, for example, EGFR, as I said. You can increase the driver count. Then came the limited multi-gene DNA panels, and you also started to get TMB. But then, in order to the comprehensive DNA panels are to be tested by comprehensive genomic profiling, and fusions are looked upon ideally by the complementary RNA-based testing. So now, if you look at the the distribution of DNA and the RNA fusions, so 14% of these patients will have fusions in the ROS1, RET, ALK, MET, NTRK, NRG1, and a few others. So if you do not look at the RNA-based, detection of actionable fusions, so you're going to miss 14% of patients. So whenever you are looking at your, testing exercise, you must look at, I think most of these labs today are incorporating RNA, fusion testing along with the DNA multi-gene panels. So you must ensure, because otherwise you have the drugs against ALK, ROS, RET, NTRK, and MET. So you will miss these important mutations, and these could be life changing for a given patient. So I think RNA fusion testing is critical today when you're ordering a NGS for any patient with non-small cell lung cancer. Next. So I think this is to showcase the importance of you doing the RNA in patients with large introns, repetitive introns, low tumor sample, or complex genomic events. And these are some of the genes which are examples which can be picked up on the DNA and RNA next generation sequencing. Next. And that's the importance of picking up a genetic mutation and treating, because patients with driver positive mutation will have a suitable target, and therefore their survival is much better than as compared to patients where the driver is negative. Next. So I think you all know these drugs and the mutations. So I'll not go into the details of this. Next slide. So I think, again, a similar slide, because you have the drugs against EGFR, ALK, ROS, BRAF, NTRK, RET, and MET exon, and even others are there, which will just follow. Next slide. Right. So I think these are evolving ones. And, for example, for HER2 exon 20 insertions, we do have the J&J drug available by the name of amivantamab. And it is, used in the first line setting for along with chemotherapy. And for HER2 mutations, we do have drugs in the second line. KRAS, again, is in the second line. Next slide. So I think the whole idea is to now decide as to how to identify these mutations. Ideally, a biopsy tissue is very, very important. If the bone biopsy is done, it can be suboptimal due to decalcification or degradation of DNA. But now, of course, we've come to a stage when we are talking about liquid biopsies, in which we are looking at the cell-free DNA in the plasma, which is released by apoptosis of from the tumor cells. And mostly, as I said, we are looking at broad NGS, for DNA and RNA. So next slide. Okay, so now a few genes, as I think we've already shared that the NTRK gene, RNA GNS, NGS is the most sensitive, although, one can do IHC FISH, but the tumor, is wasted in doing these tests. So I think most of the physicians are looking at RNA NGS for NTRK. Next, a couple more examples. MET exon 14, mutation. Again, RNA is the most sensitive. Next. And we have capmatinib and, tepotinib for this. RET fusion, again, although the incidence is very small, but then there's an increased sensitivity with RNA NGS. Next. Oh, so I'll not go into the PDL1 because there are companion diagnostics and complementary diagnostics, and you're looking at the tumor, PD1 positivity by and large. Next, or PDL1 positivity. Next slide. So this is, the 2024 guideline for adenocarcinoma. Testing should be conducted as part of broad molecular profiling. So broad molecular profiling would include, for example, 300, 400, 500 genes. Although you are looking at, these 10 or 12 genes, but then, the broad panel can give you some biomarkers which may tell you that the immunotherapy may not work and so on. And it adds to the data. And in the squamous cell carcinoma, again, although the incidence of ALK, KRAS, etc., would be, ALK and EGFR would be 1%, 2% in that vicinity. But then if you pick up a patient there, well, then one can, benefit these patients. Next slide. So these are, again, the gene abnormalities which are targetable. Next slide. So I think we have to ensure the availability of sufficient tissue, and then conservation of tissue is very important, which should be highlighted with the interventional radiologists, the pathologists, and so on. Next. So coming a few words about liquid biopsy. As I said, the tumor is shedding the DNA, and you can look at the multiple DNA abnormalities, the RNA expression and fusion transcripts, again, released from the tumor cells. And you can look at certain other, CTCs, which have not sort of caught today, in the day-to-day practice. Next. So a word about, current sequencing approaches for cfDNA. The most important for us practical is the mutation-based sequencing approach. A methylation-based sequencing approach is used for early detection of malignancies. And this is, still experimental, the fragmentation-based sequencing approach. Next. So again, these are, 2 or 3 PCR-based and NGS-based tests which need to be performed on the DNA like you do on the tissue if the tissue is not available. And one is even looking at, cap sequencing, which is highly, specific, and but it is high cost. But then, there is a role which could be there in the future for looking at small amounts of DNA mutation. Methylation, as I said, again, is looking at early cancers, and fragmentation patterns are, again, high cost and still, not incorporated in the day-to-day practice. Next. So a word about liquid biopsy. In a brief report, they demonstrated in 138 paired tests that tissue liquid concordance rates at the diagnosis are similar to previously published findings, that is 80%. But when you look at the concordance at the time of progression, it falls down to 40%. And therefore, if, so next slide. So, but the point is that if you send the blood, you can, if you get a diagnosis there, one can start the treatment early because the tissue will take a little more time for the biopsy and the NGS to come in. Next slide. So what is the role of liquid biopsy for biomarker, detection? Plasma first approach, if negative, but you need a tissue diagnosis all the time, 70 to 80% specificity and nearly sensitivity and 100% specificity. If you get it positive, but then you need to honor that. Sequential approach is again used if the tissue is, the point is that in the Nile study, if you do both, then the increased detection of an identifiable guideline recommended biomarker by 48%. So there are physicians who are sending, upfront tissue and liquid in order to, get the identifiable biomarker. So, but it has to be certainly done if the tissue is not available, because as I said, the concordance is to the tune of 80% plus. Next slide. So I think I'll skip these slides. Next, I think there's the concordance, and then there is a role for clearance of EGFR activating mutations in cfDNA, which you can do on the follow-up, which one can look at the ddPCR or even the NGS based. And then, of course, as a mechanism of acquired resistance, one can look at the ddPCR for T790M, or you can look at, the other, resistance or the escape mechanisms for identifying those, abnormalities and treat them suitably. So osimertinib is used in T790M after the patient has failed, say, to first or second generation TKI. So I just wanted to add the last three or four slides. Next. So what happens to a patient who has progressed after osimertinib? So, if you look at this paper, amivantamab, which is available, plus chemotherapy, with or without lazertinib in EGFR mutant NSCLC, has been, approved by the NCCN guidelines in the Mariposa study. So just show you the results. Next slide. Amivantamab chemotherapy, improved the PFS and intracranial PFS versus chemotherapy in a population with limited options after disease progression on osimertinib. So if a patient is progressing on osimertinib, one can use the combination of chemo and amivantamab, which is, approved in the NCCN guidelines. The last slide, I guess. So if you look at the EGFR, this particular section, subsequent therapy, amivantamab and carboplatin pemetrexed combination in non-squamous is approved after the failure of a patient on osimertinib. So like this, you have the guidelines from NCCN depending upon the mutation which you identify. You have first line and second line and subsequent therapies for various gene alterations. So it becomes very, very imperative and essential on our part to do a suitable testing, DNA and RNA in the biopsy. If that's not possible, so kindly send a sample for a liquid biopsy, which has reasonably equal concordance with the tissue testing. So I think with this, I thank the organizers for inviting.
Thank you, sir. Thank you for your excellent talk. And as we move forward, I would like to invite Dr. Aparna Dhar for the session sponsored by Akailo. And ma'am is Director, Hereditary Precision Oncology and Genetic Counseling at Max Institute of Cancer Care, Delhi. And doctor is going to speak on molecular reports in advanced NSCLC, how to optimize report structure, molecular tumor board, and input and actionability. Over to you, ma'am, for your talk.
All right, good evening. Can you see my slides?
Yes, ma'am. Just make it full screen.
Yeah, I'm just doing that. Okay, brilliant. Okay, we're good to go. All right, so good evening, and thank you, Dr. Sumant, for the kind invitation. And I've been given the task today to walk you through the nuances of, a good molecular report, a good ideal somatic report, and how the role of molecular tumor boards actually help us interpret these reports. So let's get started. We know that lung cancer is possibly one of the most molecularly diverse cancers, and particularly our NSCLC subtype. And what we've done is that we've evolved from treating it as one large homogeneous group, and you slowly moved on to categorizing it based on its histological subtypes. And now if you look at the adenocarcinoma cohort, and from the adenocarcinoma, if I just look at, if I look at the pathology, sorry, and I look at the adenocarcinoma cohort, if you see it's molecularly very diverse, and even NCCN guidelines recommend biomarker testing upfront in those advanced metastatic cases in both adenocarcinoma and the squamous cell subtype. In
Ma'am,
fact,
sorry for intervening. Your slides are not moving.
Oh, okay, hold on. Oops, sorry. I'm just going to stop sharing and restart here. Just give me a minute. Is it moving now?
No, ma'am.
Mm. Okay. All right, let me just very quickly send it to you then. I don't know why it's not moving. Sorry, just give me a second. Should we get the next speaker and I can just send this to you and then I can start so you're not wasting
Ma'am,
time.
we can see your slides. You can go without inputting slideshow mode.
Okay. So when it's moving like this, you can see it,
Yes, ma'am.
but if I'm sharing it, it's not moving. Is that right?
Yes, yes.
Okay. All right. Okay, so I think I've got somewhere here. So right. All right. So we do know that with the NCCN2, it does recommend for biomarker testing upfront in the case of adenocarcinoma and squamous cell subtype. But in addition, even in those early stage, a minimum of EGFR ALK ROS1 is strongly recommended, especially since we know that in the presence of these oncogenic drivers, immune checkpoint inhibitors are contraindicated. And the sample type, we've already heard Dr. Agarwal speak, is tissue biopsy. Tissue is an issue, we go on to liquid, and now, in fact, we're even doing complementary testing of tissue liquid up front so as to we can actually target and find actionable mutations. And around 35 to 40% of our NSCLC cohort would molecularly match to a potential target. And this is why next generation sequencing, profiling, and report structure becomes extremely important. Understanding which test you've ordered, its limitations, its pros and cons, and how to interpret it is extremely crucial. Now, there are a number of ways to test. We know that the very old-fashioned method was that single gene testing, that sequential testing of RT-PCR, IHC, FISH, etc. But we have moved to next generation sequencing, and this was a very nice study that came out from albeit the Western world, but it very beautifully illustrates that single gene testing versus NGS. NGS was far more economic. It was, from a tissue perspective, wiser. And because you had a higher rate of molecularly matched patients, there was a better PFS and a better OS. Now, this was a 70-year-old male, an Indian patient that had come to our clinic. It was metastatic NSCLC, adenocarcinoma, ex-smoker, had recently given up tobacco. And EGFR testing was done on the Biocartis IDELA platform. Again, a very, very good platform. But the EGFR came wild type, and all the other biomarkers also came negative. So his primary physician decided that they were going to give him immunotherapy with chemotherapy. He came to our clinic for an opinion, and we retested him using next generation sequencing. Because the tumor was exhausted in the sequential testing, we opted for, is this showing? Okay, so we've opted for a liquid biopsy, and in this case, we did ctDNA, and it reported an exon 19 deletion. So why was there a discrepancy here? Well, the exon 19 EGFR was reported by ctDNA. This particular variant was not detected. It was not part of the Biocartis IDELA platform. So you have to be very careful as to what technology are you requesting, and when you're reading those reports, interpreting the test methodology becomes extremely important. Now, in addition to this, CLIA NABL CAP certification, this is what our laboratories tell us, oh, I'm CAP certified, I've got NABL certification. This is not external quality assurance certification. Laboratories can quite often certainly have them. They do their assays, errors do occur, and this is not infrequent. And this was such an interesting study that came from the European externals quality exercise of a very simple gene, EGFR, single gene testing, which was performed in 2014 and was subsequently published, which demonstrated error rates of up to 35%, and in some laboratories in detecting just an EGFR mutation. So you can imagine where we are when it comes with next generation sequencing interpretation. So how should it be performed in a diagnostic lab? I'm so sorry, this was supposed to be animated, but so the AMP guidelines very beautifully illustrate the mechanism of performing NGS in a laboratory, in addition to variant calling. And most laboratories do adhere to this and other guidelines and standards. And they clearly say that when they are reporting variants, because they aren't necessarily mutations, they're just sequenced variants, and these should be classified as either tier 1A or tier 1B. And these are essentially variants of strong clinical significance, which we should be actioning in our clinical practice. That's level A and level B. Tier 2, variants of potential significant, potential clinical significance. They might be FDA approved therapies for it, but in another different tumor type that you might want to use in your tumor type, or have a small published study with small consensus that may be actionable. And then tier 3 is a VUS. You do not target a VUS. Their biological significance is unclear. But what's very interesting is that unlike germline VUSs, somatic VUSs are more likely to be reclassified as being actionable tier 1, but don't take any action on it till it's not properly documented. Now, we have to also remember what's the best test for the target. Often RNA is much better than DNA, and we've just heard Dr. Agarwal talk about it, particularly when we are talking about those very long genes such as your NTRK genes, or genes where we're looking for fusions, where we're looking for splice-like variants like your MET exon 14 skipping. So this is data from the MSKCC group, which was looking at over 200 patients that were negative for any actionable variant on DNA, in which interestingly enough, 14% of them harbored a fusion when tested by DNA and RNA. I can't stress more enough, check, double check, or triple check all those reports that come in with the mutation type and the recommended biomarker. A lot of times we do see errors, and there are a host of sites that are available and well documented and approved. This is an ideal NGS. These are some of the websites that actually are well documented, that are well established, that help us actually analyze and understand these mutations. That are they truly actionable? Are these reportable mutations? What is the targeted therapy that is associated with it? Just because we know that every EGFR is not going to respond to a particular type, is going to respond to first gen or second gen or third generation TKIs. You've got to be very careful what you're targeting. And these are some very good sites that we do tend to use this support. With testing, I think it becomes extremely important to decide what you're looking for. Since this is NSCLC, you kind of want to look at the whole biology, because it's not just about those actionable biomarkers, but it's also those passenger mutations that could inhibit those driver mutations, or that could contraindicate. So I usually, especially in the lung, I do like going in, especially on a progression, I do like going in for a much more bigger panel. Up front, I'm quite comfortable with those very standard, those very standard 2025 gene lung cancer panels. But once you move forward, once you progress, I think it becomes important to look beyond that. And also looking at all the various validations that the laboratory has. We've got laboratories mushrooming and saying, oh, we did the best NGS, we did 500 genes or 200 genes. Looking at the validation, what sort of quality control was there? What is the limit of detection? Understanding the methodology becomes extremely important. Now, when we look at our next generation report, a somatic report in particular. Some of the things that should be very clearly mentioned is obviously patient demographics, the diagnosis, the name of the test, the tumor content, the sample ID, the formalin block that you're testing, and where was that site of biopsy. It has to be very, very clear. Your mutations have to be very categorically mentioned as to where's the codon change, the protein change, which exon, type of mutation, what is the cosmic ID. There has to be documentation proving that, yes, what we are reporting is a known actionable mutation, a known actionable pathogenic mutation. In addition, what classification, was it AMP or was it ACMG figuring germline, what classification was used in reporting these variants? The methodology needs to be very categorically mentioned. Which assay, what are the limitations, how many genes are tested, what is the coverage of these genes that have been tested? The type of mutation, is it a frame shift, is it a point mutation, has to be very categorically mentioned. Now, why we've put all of this, and this is what an ideal NGS report should look like, with everything mentioned and very clearly in a very ambiguous, clear way it should be mentioned. The complexities come in when we get multiple mutations and we don't know what's the next step forward. And what's becoming a trend, and I know we have it in our clinical practice in our hospital, is a molecular tumor board. Now, the key aim of molecular tumor board is not to do cowboy oncology, not at all. It's actually to identify and discuss all the potential therapeutic strategies, majority being evidence-based, based on genetic analysis for patients who are not responding to the standard care of systemic therapies. And it's not just a one-man show, it's a multidisciplinary approach. You need your surgeons, you need your medical oncologists, you need your radiation oncologists, you need your geneticists, your molecular oncologists, you need your bioinformaticians, your pathologists, your nurse coordinators. You need everyone who's involved in that patient's treatment journey, because it's inputs that come in not just from the molecular report, but from various other disciplines that becomes extremely important. You want to factor in the performance status, the comorbidities, before you come up with, a combination. You have to be very cognizant of the fact that can my patient actually tolerate, if I'm going to be doing all these multiple therapies combined together. It allows us to get a perspective from everybody in identifying and understanding what could be a potential target. Is this a platinum sensitive tumor? Is this a platinum refractory? What is my next generation report doing? And as a molecular geneticist, one of my key roles is that before we enter the tumor board, I analyze my report from start to finish. I read it through and through. I look at the variants. I look at its clinical actionability. Never trust a report as it comes, irrespective of who your service provider is. You'd be surprised as to what kind of errors can be reported across the board. And some of the key benefits that I have seen is that with all of us working in a synergistic approach, what we get is that it helps us navigate and understand our complex reports for sure. But what you're doing is you're actually translating all that molecular alterations into clinical indications. So you're improving the management of your cancer patient, of the cancer based on targeted therapies. And sometimes it's just fine saying that, you know what, I don't think the NGS report actually is giving you anything of clinical significance, and knowing when to stop. And I think when you work in that multidisciplinary approach, you're kind of very careful and you're aware of not going, kind of cowboy oncology, and trying to do it as evidence-based as possible. And I want to end with this particular case study, which I personally think sums up my talk. So this was a 59-year-old male, NSCLC, at the time of diagnosis, molecular profiling, next generation was negative. So we started with cisplatin and pemetrexed, maintenance pemetrexed, and there was progression after 13 months. So at this point, the oncologist took from the metastatic cervix tissue testing. Interestingly enough, I'm not sure how this happened, we went for the Oncomind tumor mutation burden panel, a 409 gene panel, and this is what the results came. The oncologist was thrilled. I found a red mutation. Can we give selpercatinib? Obviously, a lot of excitement. So when we went back and we looked at this particular report, interestingly enough, this is the tumor mutation burden panel. So from the get-go, incorrect panel was sent. This particular panel, this assay is not designed to report mutations. It's designed to calculate tumor mutation burden. So whatever results it kind of splurts out, I would take it with a pinch of salt. And sensitivity is very low in pulling out actionable, not actionable, just reporting mutations. Second is, as I said, I always check, double check, and quadruple check all my alterations that I've reported. So before we targeted this RET mutation, I went back into the databases and had a look. Interestingly, because it had a pretty high VAF of around 60%, that was a germline indication. So we went back and we saw that this is actually germline likely benign. And interestingly enough, this particular change in the RET mutation was benign. So this was something that should not have been reported. And it becomes so important actually checking these mutations before you start your targeted therapy. So what do? We then decided that, look, obviously it was a wrong test from the get-go. Unfortunately, tissue was exhausted. So we sent for a liquid biopsy. And what we found was an EGFR classical exon 19 deletion and a BRAF V600E, two actionable biomarkers. What do? And there's a TP53. So we took this back to the molecular tumor board where everyone gave their inputs. And what we recommended was that we would start off with a combination of osimertinib. Now we know BRAF is a non-resistance mechanism to your EGFR TKIs, so we put the patient on a MEK inhibitor. The reason being that dabrafenib plus trametinib plus osimertinib are very toxic, and since MEK is downstream to BRAF, we consider doing osimertinib with a MEK inhibitor. So far, so good. The patient is doing well. And I think for me, this is the best way I can sum up my talk, that it is a synergistic approach it is a multidisciplinary approach where everybody has to work together, and it becomes really important reading a report, double checking what the report says, and working as a team in helping our patients have better opportunities to with therapies. On that note, thank you very much for your patient listening, and apologies for the technical glitch.
Thank you, ma'am. Thank you for your excellent talk. And as we move forward, now I would like to invite Dr. Kanika Sharma Sood, and ma'am is Clinical Lead and Director, Radiation Oncology at Dharamshila Narayana Super Specialty Hospital, Delhi. And for her talk on when is SBRT a reasonable consideration for stage 1 NSCLC, and should we ever consider adjuvant systemic therapy? Over to you, ma'am.
Thank you for the kind introduction, and thank you, Dr. Sumant, for having me here to speak on a very interesting topic, which has always been debated upon, but I think we have come a long way from those debates, and SBRT has now actually found a space which I will define in the coming slides. So the key questions which were allotted to me were that when is SBRT a reasonable option or a consideration for stage 1 non-small cell lung cancer, and should we even consider adjuvant systemic therapy in this subgroup of patients? So before I proceed to answer these questions, let's recapitulate what is the segment we are talking of. Stage 1 is the segment where we are talking of T1 and T2 disease, and this encompasses the tumors which are less than 5 centimeters, basically. So tumors less than 5 centimeters are stage 1 N0 particularly, and here is where I want to figure out or put up the consideration for SBRT. So this particular subgroup is the one which is seen in almost 20% of cases in the US. However, in our country, the numbers which we see in this stage are pretty low, and practically 90% of the patients which come to our clinic are inoperable. Having said that, even in stage 1, it is an established fact, and we know that the gold standard for treatment for this subgroup remains to be surgical lobectomy with mediastinal lymph node dissection. And some scenarios where the health does not permit this standard gold standard treatment, their sublobar resection or radiation is an alternative. And SBRT in the last 2 decades has been found to be safe, effective, and efficient way of treating this subgroup of patients who are medically and functionally inoperable because of its favorable profiles. So to just give you an overview, I will not go into the nitty-gritties of SBRT, what SBRT basically is doing in comparison to the conventional radiation. So when we are embarking upon SBRT, we are trying to give very high dose of radiation to a very accurate area, which is achieved by certain coordinate systems by which we are trying to chart out where the tumor is, and we are also tracking the movement of this tumor, by virtue of which we are able to give very high dose by less number of beams and in a lesser time. And at the same time, we are preventing that high dose to go to the adjacent organs as well. So the biggest advantage one sees, apart from the local control these ablative doses give, is that the overall treatment time is shorter, side effects are lesser, and this is something which is desirable in our elderly patients, especially these subgroup of patients which actually go for SBRT are the ones who are mostly octogenarians. So this is the biggest advantage. And of late, the developments in the linear accelerators is such that practically all centers now have the capability of performing SBRT. So that is why SBRT is finding place. But if you ask me that what could be the scientific evidence based on which you can offer this, we all know that the 3 trials which were aimed to prove the efficacy or equivalence to surgery died because of their poor accrual. Whatever we have definitely is because of the case controlled studies and these case reports which were published in the last 2 decades. But maybe 3 to 4 years down the line, we will have this randomized trial study results coming up, because the accrual, fortunately for the Veterans Affairs phase 3 study, which is comparing early lung cancer surgery versus SBRT, it has reached its accrual in July 2023. So with this, we will have some information which would be a phase 1 randomized evidence to show the equivalence. But so far, what has been done is courtesy this gentleman, Mr. Timmerman, who is the father of SBRT when it comes to lung or it comes to liver. He published his initial study somewhere in 2003, so it's almost 2 decades. There, he found that SBRT is a reasonable alternative to the patients who cannot be offered surgery. And subsequently in 2010, he published the phase 2 data results, where we could see that the overall survival rates at 3 years were equivalent in surgery versus the SBRT arm. And similar results were produced by Riccardi et al. Almost 3 years later, where OS was seemingly similar in the SBRT and the surgery groups. Then a lot of dosimetric studies went on in the last 2 decades. The most important ones to mention is the Onishi et al., which established the dose which is actually significantly helping in achieving the local control and OS. So a biologically equivalent dose of 100 gray was established on basis of this particular study. And ever since, this is considered a benchmark whenever we are planning SBRT for any patient. Subsequent studies also did show that the tumor size matters. The size of the tumor, if it is less than 3 centimeters versus more than 3 centimeters, efficacy was different. The local controls were different. So was found that despite good controls, there were a segment of patients where we were finding progression at distant sites. So this information was penetrating into the further studies. And as of now, the current scenario, the current picture of SBRT we see is based on a lot of studies which have established the dose fractionation, because there were concerns related to toxicity. If I can just summarize these trials, which were primarily the radiation trials, these studies did show that local controls at 3 to 5 years ranged between 85 to 95%. And overall survival also was to the tune of 50 to 95% across all these studies. So this formed the platform for SBRT. The subsequent RTOG trials, after establishment of the efficacy, could put a gambit. They extended the tumor size from 3 centimeters. The subsequent studies incorporated tumors even up to 5 centimeters. So the efficacy in tumors up to 5 centimeters was also found to be good in terms of local control. However, again, as I have highlighted here, we could appreciate some amount of distant failure in some subgroups, and probably this would be the patient which I would talk of in the adjuvant treatment arm that would require something additional in addition to the SBRT. Overall, the RTOG study group local controls across all T1 to T3 have been found to be above 70% even at 2 years. So what these studies tried to do is, in the last 2 decades, they tried to address the toxicities, because there were fears regarding esophagitis, pneumonitis, and chest wall rib fractures as well. And there was a lot of ambiguity on patient selection as well. So these studies have addressed these, and now our axial imaging, functional imaging, and our gated procedures have also refined in the last 2 decades. Based on that, now if we select a patient, firstly, we want to know where is the lesion. So based on the location of the tumor in context to the bronchus as well as the trachea, we categorize them into 3 categories. The tumors which are well away from the bronchus and trachea, that is 2 centimeters away from the structure, are peripheral. The ones which fall within the 2 centimeters of bronchi and the trachea are the central lesions, and the ones which touch this structure are called ultracentral. So till almost 8-9 years back, this area, that the central and the ultracentral area, was a no-fly zone for us, because the toxicity pattern for the tumors which were treated here was very bad, with fistulae also secondary to the SBRT procedures which were done in this area. But lately, with the understanding of dose response curves and the altered fractionation, now it has become not the no-fly zone, but it is a restricted fly zone where you have to choose patients. So these are the patients where you have to be very judiciously. So in the order of appearance in the slide, if you see, the most appropriate patient for SBRT would be a patient whose tumor is less than 5 centimeters and is N0, and the tumor is not associated with any other distant metastasis other than cranial metastasis. Few cranial metastases are permissible. It may be selectively done in patients with some minimal mediastinal lymph node disease, but this is not the category which is to be selected upfront. I have mentioned a few areas where this has been given a due consideration in certain studies, and with a lot of caution, people have attempted to go beyond 5 centimeters to up to 7 centimeters as well. And there is a coming up role of selecting patients for sequential synchronous multiple lesions SBRT as well. So for SBRT for central and ultracentral, as I told, that the understanding has improved. That is why the no-fly zone has been converted into the area of restricted flying, based on the fact that in these areas we need to reduce our dose per fraction to less than 10 gray per fraction. And several prospective studies have shown that the safest fractionation schedule in these would be 60 gray in 12 fractions. And despite the change in fractionation, the local controls still have been reasonably well, and the toxicities haven't been much. Though we all look at the final verdict of the Sunset trial to give the final fractionation schedule. So this category can also be selected with caution. So as of now, if I could give you a take home on which patients would be the ones which I can select for SBRT, would be tumors which are stage 1 and even up to stage 2 in selected cases, who are medically inoperable. So this criteria is important to understand. What makes the patient inoperable? If you look at ESMO says an FE1 of less than 30% makes the patient inoperable, and this is the patient which should go for SBRT or RFA. So we are slightly more stringent. The criteria used by us, and even in the NCCN is limited to 40%. These would also be the patients who have multiple comorbidities, have pulmonary hypertension, poor PS. But even for performing SBRT, a minimum basic requirement is that the patient should be able to lie down on a flat couch for at least an hour, because most of our LINACs, they perform gating, even if free breathing may take 45 to 50 minutes. Though with Halcyon, we have cut down the timeline to 8 to 9 minutes in selected cases, but that is a very small segment of patients which can be treated on Halcyon. So as of now, at least 1 hour of flat lying down is essential so that the patient can be selected for SBRT. So this is exactly what NCCN 2024 also says, that medically inoperable high surgical risk patients, which are determined by an MDT, not just by a radiation oncologist, after an MDT discussion, if it is deemed that the patient is inoperable, can be selected for definitive RT, and preferably SABR should be the choice of fractionation. So here, this is the minimal mediastinal lymph node which I was mentioning. Of late, we are seeing reports and few small case series being talked of, where people are also performing SBRT to the hilar and mediastinal node in a sequential fashion. And some low dose mediastinal SBRT results are pouring in, although it is not a standard practice. But maybe 5 to 6 years from now, with the effect and the long-term data pooling in, we might be able to consider even mediastinal lymph node radiation in a sequential fashion in select subgroup of patients. So now coming to our second question, that is, where do we integrate adjuvant treatment in non-small cell lung cancer? So as I showed in the RTOG trials, there were some issues related to distant failure. And adjuvant treatment definitely would consider eradication of micrometastasis and thereby improve the outcomes, but we do not have randomized prospective studies in this context as well. But the premise comes from the surgical series. Dr. Shubham is going to talk about them, where the LACE meta-analysis did reveal that adding adjuvant treatment to resected stage 1 disease improved survival by 5.4%. JPR10 trial also increased the reduced the risk of dying by 15%. So was the outcome in the ANITA and the CALGB trial, where we could appreciate the benefit of adding chemo in this subgroup of patients. However, the surgical series we all know are fitter patients, and the patients who come towards SBRT tend to be the ones who are more frail and elderly. So what about addition of systemic treatment to these patients? So if you look at the literature, the review of the 34 trials, which showed that there's a 4% survival advantage at 5 years by addition of chemo, did also show that the patients in their studies were relatively younger, because the median age was 60 years. And few studies by Flu et al. Could favorably give chemotherapy in elderly, but as of now, adding chemotherapy after SBRT for older patient has to be a rigorous screening exercise, and we have to really super select our patients who could be fit enough to receive this treatment. So based on the risk factors which were analyzed in these trials from the surgical series, the patients who we can consider for adjuvant treatment should be the ones who harbor these high risk features. Particularly, the size of the tumor has been evaluated in repeated series of studies as well. That is the tumor size more than 4 centimeters, tumors which are invading the visceral pleura. And if you have a surgical biopsy mention of LVI, then this would also be categorizing as a high risk feature. So these 4 criteria for surgical series. For SBRT, maybe we can limit the 3 ones to figure out that which patient would actually benefit from adjuvant chemotherapy. Additionally, some risk factors which have been identified are certain histological entities, particularly the large cell neuroendocrine carcinomas have been studied, and literature also says that in comparison to the other histologies, they tend to do worse. And so is true for micropapillary adenocarcinomas. Biomarker status, we heard a lot about biomarkers today. There is a role of targeted, we know, but after surgery, we still don't have a clear consensus. Mainly, firstly, the number of patients who have these biomarkers positive with actionable mutations sometimes are limited, so we don't have long series. Whatever data we have is seemingly promising when we see at this study, which was conducted for erlotinib in EGFR mutated patients in surgical series, but as of now, these are just regarded as providing advantage, but OS data is still not mature. A series which was study attempted for Geftinib actually could not be conducted completely because of premature closure. So we don't have data for Geftinib as well. One of these studies which have published.
Ma'am, sorry for intervening. You need to conclude, please. We are running short of time.
So this ADAURA study does give that osimertinib might be beneficial in these patients, but their OS data is not mature. But their DFS data definitely is promising. So with SBRT, no studies are there prospectively, but people have retrospectively tried to analyze what has happened in patients who received adjuvant treatment. And what they could establish is that it has no role in stage 1 disease. However, as the tumor size increases by to 4 centimeters, as you can see in the right panel, the benefit of adjuvant chemo does start to appreciate. So as of now, if SBRT is to be joined with adjuvant chemotherapy, it would be selected for the patients who are having tumor size more than 4 centimeters or are harboring those high-risk features. And even in the elderly, the same group has found the same parameters, that is the 4 centimeter criteria and adverse subgroup. And so I will not go through 3 studies. So if you are to consider adjuvant chemotherapy in this subgroup, it has to be an MDT approach again, taking into account the high-risk features. So as of now, treatment decision of combining SBRT with systemic treatment is not proved by evidence. It is case-to-case basis. For stage 2, for sure, NCCN has permitted. So I'll just summarize by saying that SBRT definitely is an effective treatment option for stage 1 non-small cell lung cancer, comparable to surgery, particularly in patients who are not medically operable. Adjuvant chemo may be beneficial as per whatever we see, but we need more data to support its efficacy, and integration has to be case-to-case basis. So I thank you so much, and over to you, organizers.
Thank you, ma'am. Thank you for excellent talk. And as we move forward, I would like to invite Dr. Shubham Jain, who is Senior Consultant Surgical Oncology at RGCI Delhi. And sir is going to speak on when is surgery the only best approach for stage 1 NSCLC, and when should we consider systemic adjuvant therapy? Over to you, sir.
Hi, good evening. Are my slides visible?
Sir, you need to share your screen. Yeah. Yes, sir. Just make it full screen.
Is it full screen now?
Yeah. Yes, sir.
Great. So thank you, organizers. Thank you, Dr. Sumant, for inviting me for this session. And thank you, Dr. Kanika, for making my job so very easy. Fortunately, our talks were quite overlapping in that sense. And you have brilliantly quoted and nuanced it that the main treatment or the standard of care right now for stage 1 NSCLC is in fact surgery, and it is those subset of patients who are either medically inoperable or high risk or refuse the surgery that we do consider SBRT for them. And you brilliantly consolidated all the evidence for the systemic adjuvant therapy as well. So my talk is more or less going to be a recapitulation of what you have stressed on. A bit of difference that has been there is I'll be talking more about the surgery aspect. So as we know that since 1995, lobectomy has been validated as the standard surgical approach for stage 1 lung cancer, that is T1 and 0. And these are the curves that were depicted in the study, which showed a significant survival and a recurrence-free survival improvement in comparison to a limited resection when it comes to lobectomy, which actually put lobectomy as the standard of care. But in the recent years, things have changed quite a lot with respect to surgery. The open thoracotomies are now more and more minimal access, that is the VATS and the RATS. And this is actually the graph taken from the Violet study, which randomly compared the open thoracotomy to the video-assisted surgeries, wherein we are able to see that the pain scores are much better and the physical functions that the patient recovers with are much better without compromising on the quality of the surgery or the lymph node yield at all. The second area where the surgery has evolved has been the sublobar resections or the segmentectomies, and the JCOG trial did show that the survival is almost comparable to the lobectomy for patients undergoing segmentectomy. And similar were the results from the CALGB trial from the America, that in fact now suggests that a patient with a less than 2 centimeter lesion, which is probably peripheral, may be offered a sublobar resection. Now, the difference between the Japanese and the CALGB trial was that the Japanese study exclusively studied the segmentectomies, whereas the CALGB trial studied both the segmentectomies and the wedge resections for the patients. The other area, as Dr. Kanika alluded to, was the comparison with the SABR. And as far as the STARS-ROSEL studies are concerned, there is this new study, which is the revised STARS, which also extrapolates and finds that the SABR is actually non-inferior to the VATS with the mediastinal lymph node dissection for stage 1 NSCLC, and it can be evaluated as a strong option in patients who are medically inoperable. The survival curves are hardly different, so these options could be quite overlapping and beneficial, especially to patients who are not amenable for a surgery. So again, taking the slides from the NCCN, the area where surgery definitely works for the patients with early stage lung cancers are the operable ones. These roles are very defined, that an operable patient needs to undergo a surgical exploration, whereas a medically inoperable or a high-risk patient may be considered for an SABR. Similar is the situation with the other higher stages till stage 3. Now, the second part of the talk that is about the systemic adjuvant therapy, where probably I can contribute more, is the other trials, because these, as Dr. Kanika said, have been validated more on patients who were surgically fit and post-resection. So as she said, the LACE meta-analysis is the meta-analysis that was published in 2008, and for quite long time, that was the standard of care, wherein the indications of treatment for any patient after a resection were a tumor size more than 4 centimeters, or if the nodes were positive. And these included the various trials of their time. Following this, however, things have started changing a lot. The role of EGFR TKIs was evaluated, which was initially met with not that much of success, wherein the initial trials, that is the BR19 and the Radiant trial, which compared the gefitinib and the erlotinib, were met with failures. And in addition to that, the other trials, the adjuvant trial, which again compared gefitinib in comparison to the other chemotherapy regimens of vinorelbine plus cisplatin, or the impact study, these were also not able to show a significant impact, which led us to believe that probably the EGFRs are not having that much of an impact in comparison to the standard chemotherapies. But what changed after that was the ADAURA trial, which in fact showed there to be a significant DFS improvement. And not just that, recently the ADAURA has come out with their OS data, which shows a significant benefit of all patients ranging from stage 1B to 3A, which makes it now the standard of care in resected patients with EGFR mutation. In addition to that, the other molecular target that is being evaluated now is the ALK mutation. The ALINA abstract that has come out definitely shows it that the intention to treat population ranging from stage 1B to 3A definitely has a significant DFS advantage when alectinib is administered after a complete resection in these patients. Now, that was about the molecular targets. Coming to the immunotherapy now, the IM Power 010 study definitely shows there to be an advantage of adding atezolizumab after the standard chemotherapy that is given to patients who are eligible, ranging from stage 1 onwards. But not just that, what is now being evaluated further is the use of perioperative immunotherapy. Now, if we are to see the data which comes from the Keynote 671 study, which compares the perioperative pembrolizumab, or whether it goes to the other study, which evaluates the role of the durvalumab and the nivolumab, all these studies actually are showing there to be a significant impact of these perioperative immunotherapy. And that is where the adjuvant treatment with systemic therapy is also coming in vogue, even for patients with resectable cancers. Thank you so much for the patience.
Thank you, sir. Thank you for your excellent talk. Now, I would like to invite Dr. Suman Gupta for the session sponsored by AstraZeneca, and Sir is Senior Consultant and Head, Medical Oncology, Hematology and BMT, Director at Metro Cancer Institute, Faridabad. And Sir is going to talk on reinventing adjuvant therapy in EGFR-M early lung cancer. Over to you, sir. Dr. Suman, sir.
Hello, am I audible?
Yes, sir. Now you are audible.
Thank you. Thank you, ma'am, for your kind introduction. And thank you, AstraZeneca, for giving me this opportunity. So we'll be talking about the reinvention of adjuvant therapy in EGFR mutant early lung cancer. Next slide, please. So if we talk about survival outcomes, I think survival is the thing where we all boil down to in oncology. So survival outcomes in resectable NSCLC always needs improvement. So if we see around the global 5-year OS rates in patients with resectable NSCLC, so in stage 1B, stage 2 and stage 3A, where the surgery has the main role, the 5-year survivals have not been something which we are very proud of. It ranges from around 65-75% to around 30% in stage 3A. And that has always led to oncology into believing what more after surgery can be done to improve these particular cases. Next, please. So coming to testing recommendations. Earlier, we used to do only NGS or genomic testing for metastatic cancers. But the expert consensus recommendation on biomarker testing in non-metastatic NSCLC has now also paved the way, where at least, if not all NGS, at least a EGFR and PDL1 should be done. Because as my previous speaker said, the neoadjuvant and adjuvant approaches have changed and the perioperative approaches has changed, and these two things have made the biggest difference. So EGFR and PDL1 testing is now recommended even in early non-metastatic resectable lung cancer. Next one. So the prevalence of EGFR mutation in patients with resected stage 1 to 3 non-squamous NSCLC was studied in various studies, and this is the data from early EGFR study which was presented in ASCO 2023. And EGFR mutation prevalence was around 50%, with deletion 19 being the commonest, followed by the L858R. So we always thought that EGFR mutations have been around 25 to 30% in the metastatic setting. But when we started doing a real world evidence from early resectable cancers, this was found that around 50-51% patients. And this comprised not only of a localized area, but with patients from Middle East, Africa, Latin America, and Asia. So quite a global population. Next one. So, in the current testing and treatment plans, more than 2/3 of these patients who were taken as stage 1 to 3 in this early EGFR study, more than 2/3 of these patients underwent only surgical resection, and only 46.3% patients received some kind of adjuvant systemic therapy, depending on whether it was chemotherapy, PDL1 directed therapy, or EGFR directed therapy. Next one. So after initial treatment, more than half of the patients with resective NSCLC experience recurrence in 5 years. So this has always been the problem which we have faced. Even with surgery, chemotherapy, radiation, only 40 to 50% patients will remain cancer-free. And 50 to 60% patient will have local or distant recurrence. Given that over half of the patients recover, even with a curative intent surgery, there is an unmet need for improved neoadjuvant and adjuvant treatment options, so that we have a very good OS in these subgroups. Next one. So coming to adjuvant chemotherapy, I think adjuvant chemotherapy after surgery for stage 1B to 3 NSCLC showed an improvement of around 5% with over 5 years. And at the time when this ANITA study was published, this too was a game changer, and this too became the dictum of treatment and what is to be done in all these patients. So basic. Hello, sorry, I'm really sorry for this. So am I audible, ma'am?
Yes, sir, we can hear you.
Sorry. So chemotherapy, when it was added to surgery in the early lung cancer, which was operable, there was a 5% survival advantage, DFS and overall survival advantage at 5 years. Next one, please. So as we all thought that EGFR TKI in adjuvant EGFR settings, so we had all the first and second generation TKIs which were used. So there were various trials like the Select, Radiant, Ivan, and the BR19, but none of these trials translated into approval or a change in clinical practice. Next. So the current evidence for EGFR TKI from randomized trials in adjuvant setting from these first and second line drugs did not have had some improvement in DFS, but no OS benefit. And there was a meta-analysis also done, which showed that there was a 48% of risk of reduction in recurrence, but again, there was no basic advantage in these particular drugs as they did not favor into a OS change. Next one. So we have these data that not resulted in a change in clinical practice. So the OS benefit was still, which was lacking, and this was the one which never changed our practice. Next one. Then came the ADAURA trial. So basically, It was a trial which had stage 1B, 2, 3A NSCLC with or without adjuvant chemotherapy. The key inclusions were, as in most of the trials, age more than 18, WHO performance 1 of 01, confirmed primary with the EGFR mutation. So these patients were randomized into 1:1 randomized into osimertinib 80 mg once daily versus placebo, and a planned treatment was 3 years. The duration continued until we had a disease recurrence, a treatment completion, or discontinuation criteria was made. The primary endpoints were the DFS by assessment in stage 2 to 3A patients, and key secondary endpoints was DFS in overall population, OS, safety, and health-related QOLs. Next one, please. So the DFS, which was the first which came out in a NEJM publication in 2023, clearly showed that there was a DFS advantage in both overall population and in the stage 2 and 3A population as well. Next one. So adjuvant osimertinib has significantly improved the CNS DFS also. CNS metastasis, as we all know, is the most problematic and poor prognostic factor with NSCLC. And it is also the biggest cause of deterioration of quality of life. So the updated CNS DFS analysis, which was published in JCO in January 2023, clearly showed that osimertinib had a advantage in CNS progression also. Next one. Coming to the safety analysis, basically when osimertinib versus the placebo arm was compared, there was no new adverse event was noted when compared to the primary readout or data of the ADAURA. And most of these adverse effects were manageable and tolerable. Next, please. So in order to improve OS, we need to put more effort to identify the lung cancer. Testing is a must, and collaboration is the key to success. Next. Patient may ask for treatment options for best survival probability, and ADAURA data gives us a probability of patients to remain cancer-free with long survival benefit. Next one, please. So before I end, in fact, the updates, as Dr. Shubham has said, that the updated data of OS also has clearly shown that in osimertinib, there is a clear advantage. And in these patients, especially the early lung cancer which have been operated, and if we find out a EGFR mutation, I think osimertinib is the way to go forward, and that has changed our clinical practice. I thank everyone for their patient listening.
Thank you so much, sir, for your excellent talk. For the next talk, I would like to invite Dr. Ankur Punia, sir. Sir is consultant medical oncologist, Mahatma Gandhi Medical College and Hospital, Jaipur. Sir will talk on optimizing first-line treatment strategies in driver-positive lung cancer. Over to you, sir.
So, good evening, everybody. Thank you for inviting me to this talk. So actually, my laptop is not working. I'm trying to share from my phone. I will try to share the slides. Can you see the slides?
Yes,
Yes, sir,
sir,
it's
we can.
visible.
Yes, sir.
Okay, so basically the topic given to me was optimizing the treatment in driver mutation or oncogene addicted non-small cell lung cancer. So it's a vast subject. We have now so many genes. So lung cancer has sort of become the hub for detecting more and more genes and getting more and more targeted therapy in the cancer treatment. So basically, I have taken a basic overview of these are the latest ESMO guidelines of 2023. So this gives us a basic idea of how much drivers are there in the lung cancer and what all we can target. We know all the basic ones, EGFR, ALK, ROS. But now we have multiple others like BRAF, RET mutation, NTRK, HER2, even EGFR exon 20 mutations are the rare mutations. Then we have MET exon 14, and even now KRAS is even targetable. As we can see, there are so many options for each and everything. We know EGFR is the most common, so we have the most options for EGFR, which includes TKI with chemotherapy, TKI with bevacizumab targeted therapy. So we have now multiple combinations and permutations are going on because EGFR is the most common. But even still, we are getting newer drugs and different mutations, even though they are rare, like NTRK and HER2 or EGFR exon 20. But still, we are getting newer and newer innovations in all this field. Similarly, if you look at, by the different mutations, so EGFR, we all know we have now multiple options we have. Osimertinib, though, have become the de facto standard because of the great outcome and easier toxicity, long-term OS benefit. But we are forced to use other TKIs as well because of one of the other reasons like gefitinib or erlotinib. We have data with erlotinib with either bevacizumab or ramucirumab. Maybe a subgroup of people we might give this, but we have osimertinib with more or less the same outcome. I don't know how much useful these combinations are in the scenario as such now. Then we have the second generation TKI like afatinib and dacomatinib. And we have the gefitinib with chemotherapy combination with a very good trial from our country only, which might be a good option for many patients. And though it's not updated, we have now the FLORA-2 trial in which osimertinib is also has shown good results along with chemotherapy. Though we don't have the final OS data, but it's shown an improved PFS. And similarly, amivantamab, the monoclonal antibody, has shown good results in the upfront setting, along with lazertinib compared to osimertinib. So we are getting newer and newer options day by day. So what eventually happens, we start with a TKI, the patient will progress. If patient has a just local progression, we might consider for just giving some local therapy and continue the TKI. But if patient has a multiple site or systemic progression, then the ideal way is to do a repeat testing because T790M is one of the most commonest resistance mechanism for which we can use osimertinib if we have not used in the first line setting. But now the thing is we are identifying more and more of these resistance mechanisms, and maybe if we can target these resistance mechanism again and gain another good PFS2 for our patients if we are able to identify these mechanisms. Because now we are able to identify in almost 50 to 60% of the patients if we are able to do repeat NGS or biopsy or even cell-free DNA, liquid biopsy might tell us what kind of mutations or what all things are happening with the tumor. So it might again give us another option to hit the cancer with another TKI. So this is how its treatment has evolved, and now we are getting understanding basically by understanding this resistance mechanism. I will highlight one or two studies from the last 6 months, which are basically identified the resistance mechanism and trying to target those resistance mechanisms. So we look at the ALK translocation. Now ALK again has multiple options with us. We have lorlatinib, the latest generation, then alectinib, brigatinib, and the first generation ceritinib and crizotinib. Lorlatinib and alectinib has one of the best outcome. Lorlatinib has been developed as a CNS targeting agent because majority of the ALK positive patient, almost I think say 80% will eventually develop one or other brain mets because these patients tend to live very, very long. We have look at long-term outcomes. Average survival has been in the 4 to 5 years if we are able to give the newer generation of TKIs like alectinib and lorlatinib. Again, similar things are happening in the ALK field as well, though it's not that much common. But it has been seen that patient who progressed on, they also develop some secondary resistance mechanisms, secondary ALK mutations, which can be again targeted with some mutations can be targeted with another ALK TKI, but not all. But still, we are able to identify multiple other resistance mechanisms which are being targeted, which again helps us to gain much more benefit for all these patients. And the third commonest one is the ROS1 translocation, though it's not that much common, I'll say 2 to 3%. So we don't have that much options. We had crizotinib for a long, long time. We had some phase 2 data with ceritinib as well. But now we are getting very good results. Data has been shown with entrectinib, which we get soon in India. And then repotrectinib, which has shown very good results in this subgroup. So might be a good option for these patients. And again, the same thing, patient progresses. We should try to do a repeat biopsy and repeat NGS. Though as a ROS1 is rare, we don't have that much of data regarding what kind of resistance mechanism develops. But we do have some data which might show that 10 to 20% patients can again be targeted with some or other TKI when they progresses. Now, the next thing which has been one of the shown good results in upfront as the BRAF mutation, because without this TKI, usually these patients test to very poorly. Patients with the BRAF mutations have a very aggressive course. They don't respond well to chemotherapy, not that much well to even immunotherapy, and they progress very fast. So with the combination of this dabrafenib and trametinib has shown very good results in the first line setting and even the second line setting. So again, it's a very good option for us. So we don't have any other BRAF inhibitors with us, which can be used. We have some phase 2 data with other BRAF inhibitors, which can be used and have shown good results. But we don't know whether we can interchange that or the second BRAF inhibitor will work after progression on the first line BRAF inhibitor. So now looking at basically about how can we optimizing? Basically, we are optimizing by choosing the best agent upfront in the first line setting, if possible, for a patient who can take any sort of medicine, and then how to justify giving second line treatment and delaying the use of chemotherapy and try to target what can be targeted. So one of the most common thing which has been identified has been the HER3. HER3 as such is indolent. It doesn't have any pathway which leads to it. We have studied basically from breast cancer, where we know that it dimerizes with HER2 basically, and then leads to eventual cell proliferation and all. But now we are seeing much more of these mutations in different cancer, and it role has particularly shown in non-small cell lung cancer. So as we can see that around 80% of this non-small cell lung cancer are expressing HER3 at a high level. HER3 implications are not that much common, but the expression is quite high. So that way, and also it's one of the proposed resistance mechanism of EGFR therapy in around 4 to 5% patients eventually develops HER3 amplification or overexpression, which might be the cause of developing resistance to EGFR TKI. As we can see in this, as I discussed, different kind of resistance mechanism which has been seen, whether we use osimertinib or whatever different kind of drugs, we see multiple mutations eventually develop. Patient who's taken first line of osimertinib, though we don't know in majority of the patient, but many we see they develop different kind of EGFR mutation. They develop different kind of mutation like BRAF or MET. There is conversion to small cell or squamous cell or different pleomorphic. But even in we see patients who has taken osimertinib in the second or third line, they also develop different kind of mutations, similar but also like ALK or BRAF, and again HER2 mutation has been seen in these patients. So we are able to identify now more and more targets which can be targeted by different kind of therapies for this oncogene-related lung cancer. So this study has shown a very good thing that as the HER3 expression increases after EGFR treatment, so this might be one of the cause that as the expression increases, is don't let that EGFR TKI do its work, and might be one of the cause in not on all patients, but at least a few patients, which might be targeted, as we are now developing more and more targeted therapy, particularly now the era of ADCs, basically antibody drug conjugates. Now multiple ADCs have come into the picture, and basically one of them, HER2, has changing the breast cancer scenario. So multiple others are in development, which might develop, change our scenario in other cancers as well. So then now there are multiple HER3 antibody conjugates are in development. The most ahead is the pertuzumab deruxtecan, which we are going to basically discuss. It's sort of like trastuzumab deruxtecan, similar chemotherapy component, but linked to an anti-HER3 antibody. So there are basically HERTHENA study has been there. HERTHENA 1 and 2 is HERTHENA 1 study is basically phase 1-2 study. Patients who has taken therapy and then they were randomized, or they were given the drug and the responses were seen. Phase 3 HERTHENA study has started in the second line patient who has progressed on osimertinib, then they are randomized between this pertuzumab and chemotherapy. So as we can see in patients with different kind of EGFR mutated in this phase 1 study, majority of the patients showed some kind of a response, irrespective of type, whether what kind of EGFR mutation was there, whether it was related to EGFR or some other mutations were there independent of EGFR, like MET. But the thing which we saw is that responses were seen irrespective of HER3 expression. Yes, the more the HER3 expression, the chances of responses were higher. But even with patients with no or low HER3 expression showed a response. So this was a Harthina lung 1 study, basically a phase 2 study. Patient who are EGFR mutated, who has progressed on systemic therapy as well as received a TKI. So it was basically a dose finding study. And we see the responses were seen around 30% of the patient responded. So this showed that around 30% of the patients who progresses on EGFR TKI might respond to a second line ADC, and this might be one of the mechanism of developing resistance to that. So it's shown a good even PFS of around 5.5 months, median duration of 6.4 months, and overall survival of 12 months post 2 to 3 lines of therapy. Again, the same thing which I have shown earlier. They showed response irrespective whether type of resistance mechanism was EGFR dependent, independent, or mixed was there, or even none was identified. Responses were more or less around the tune of 30% in irrespective of type of resistance which developed. So basically, HER3 bypass whatever the resistance mechanism was developing just based on HER3 expression. And we're looking at the correlator marker analysis based on how much stronger the expression was. Yes, we see the responses are more in patients who have a very, very strong expression. But even in patients with a low expression, responses were seen, not that much, but still few responses were seen. If we look at the safety summary, yes, when any new drug comes, there comes neurotoxicity, but not any, atypical toxicities were seen with this antibody drug conjugate. More or less myelosuppressive things were seen, thrombocytopenia, neutropenia, some GI toxicity like nausea, constipation were seen. ILD was seen in the tune of around 5% in the study. And one of the other subgroup of this phase 2 study was basically for patients who had brain metastasis. So this is basically Harthina lung 01 CNS analysis. You can see that even in patient with CNS brain metastasis, the responses were seen in around 20-30% patients. Even patients who are irradiated, who are not irradiated, and a CNS disease control rate of around 80% was seen. So yes, we know by looking at this that ADCs work in brain mets as well, though it was postulated that there are bigger molecules, they might not penetrate the blood-brain barrier. But we are seeing that yes, patients with even brain mets are responding who are multiply treated with TKIs, chemotherapy, but are still responding, and majority of are stabilized with that brain metastases have stabilized with these drugs. So looking at the same thing in CNS progression, was at 12 months, 23% was seen with the history of brain mets, and patient without a history of brain mets, only 3% patient showed a CNS progression. So this drug has a good CNS activity as well. So as I told you that phase 3 study is going on in the second line, patient who has progressed on osimertinib to compare versus panitumumab versus the physician choice of chemotherapy. So one of the another thing which came was the Mariposa 2 study, in which patient who had progressed on osimertinib were then randomized to either giving just chemotherapy, giving amivantamab plus chemotherapy, a dual antibody, or amivantamab chemotherapy and lazertinib, again a phase, third generation EGFR TKI. So we can see that PFS was improved with using the combination. Not that much of difference by adding lazertinib, but yes, the PFS was improved when we added amivantamab. So again, it was able to bypass some of the resistance mechanism because it targets both EGFR and MET. So it might be able to at least target those patients who had higher MET amplification or even MET mutations, which happens in around 10 to 14% of patients post osimertinib. Similar thing was seen in the intracranially. Again, it showed a good response rates. It didn't make much of a difference by adding lazertinib, but the PFS was improved in patient with CNS metastasis as well. One of the second important study which came was the FLORA-2 study, in which basically patient was randomized osimertinib versus osimertinib plus chemotherapy, more like what the Jeftinib study we have from TMH and Japan. So balanced baseline characteristics, as we can see, the PFS was significantly increased, almost 8 months, 25.5 versus 16.5 months. The same was seen by independent. It was slightly more, 30 versus 20 months, which tunes more in line with the FLORA-1 trial, which showed a PFS of 19 months. And even patient who had brain mets or didn't have brain mets, it showed a good difference. Patient with CNS mets, there was a 10 months PFS difference. In patient without CNS mets, there was 7 to 8 months of a PFS difference. And those in the slide slightly cut. The PFS difference was seen irrespective of EGFR mutation as well, whether it was exon 19 or 21. If you look at the overall response rates, they were slightly increased with the addition of chemotherapy, but not that much of a difference. You look at the PFS2 was not significantly increased by adding by addition of this drug. You can see there is not that much of a difference, 30 versus 27 months, and we have median OS is still immature, and we don't know exactly. We might know in the next year or so whether OS was actually improved by adding osimertinib with the first line therapy. Safety, yes, toxicities will increase when we use more and more of combination of drugs. Grade 3 adverse events were seen in majority of the patients. Serious adverse events were seen in around 2/3 of patients with the combination versus around 30% in the just osimertinib therapy. So they included, yes, patients have definitely benefited, and more so the best benefit has been seen in the patient with CNS mets, where the PFS improved by almost 10 months, because these patients tend to do not that much well eventually on progression. So another important thing was presented in the last year ASCO was this Keynote 789 study, whether immunotherapy will work in these patients who has progressed on TKIs. So they raised some data earlier, phase 2 data. We showed that yes, patient might respond to chemotherapy along with immunotherapy in the patient who has progressed on TKI. So this was based on the same thing. Patient has received TKI, now they were randomized to immuno plus chemo versus just chemotherapy. So baseline characteristics are well balanced. So we look at the co-primary endpoint of PFS, and we look at it, it's not, there was not significant difference. PFS was around 5.5 months in both. At 12 months, around 4 patients more were progression free, but at 2 years, the difference came out to just 1%. Looking at the OS, again, the same thing. OS was not changed. It was 16 versus 14.5 months. And we look at the OS at 2 years, at 3 years, it was 14.6 versus 11.4%, not much of a difference. Maybe we know that few patients develop resistance mechanism which might respond to immunotherapy, but though we are not able to identify those exact mechanisms. So until down the line, we're able to identify more and more of these resistance mechanism, we might be able to target better the patients who will, yes, benefit from addition of immunotherapy in this oncogene-addicted lung cancer. The similar thing was seen that in this trial that OS was not forest plot. We can see none of the subgroup has any benefit from addition of immunotherapy, even by PDL1. Yes, if you look at the patients who were PDL1 positive, this was slightly interesting thing that higher the PDL1, higher were the chances of patient had slightly better OS. If you look at the long-term outcome, basically at 2 and 3 years, at 2 years, around 10% more patients were alive, and at 3 years, 5% more patients were alive. So maybe this is one subgroup which might benefit. We don't know, but we need further studies. Responses were more or less the same. Safety summary, yes, we add a newer drug, we get more of the adverse events, but they were not that much of more, and they are basically immune-related adverse events, which we are now well versed in how to manage those adverse events. So thank you. That's all what I have to say.
Thank you so much, sir, for your excellent talk. For the next talk, I would like to invite Dr. Mohit Saxena, sir. Sir is senior consultant, Department of Medical Oncology, Marengo Asia Hospital, Gurugram. Sir will talk on combination of IO and emerging new treatments in early disease. Over to you, sir.
Good evening. Thanks, Dr. Sumant sir. Thanks, organizer, for giving me the opportunity. My slides screen is visible.
Yes, sir. Screen is visual. Make it full screen, please.
Okay. And now it's, I think you can.
Yes, sir. It's visible now.
It is, the slideshow is there. Okay. So the topic given to me is combination of immunotherapy and emerging new treatments in early lung cancer. So we all know that in the early lung cancer, the basic treatment is primarily, it might be surgery or it might be radiation. And of course, chemotherapy has definitely role. Sometime before surgery, sometime after surgery, sometime concurrent with the radiation. But the idea is where to fit the immunotherapy with among these treatment. And I would like to discuss this point that the data of the combination of two IO, that is like NeoIP, which we are using in stage 4 CA lung, or immuno plus targeted therapy, that is atezolizumab, which we are using in stage 4 CLL. So these data I couldn't find in the early lung cancer. So my topic will be primarily restricted to how the immunotherapy agents are combined in the treatment of the early lung cancer along with the surgery and radiation. So that with that I would like to start. And of course, there are many drugs and there are many trials, but primarily I will focus on phase 3 trials only because these are the more relevant for all of us. So now if you look at if the primary treatment is surgery, then how immunotherapy can be fitted? It can be given in the neoadjuvant form, whether means before surgery, along with chemo versus, and we can compare with the chemo. That's what we did in the Checkmate 816 trial. It might be perioperative, that is before surgery, along with chemo, and after surgery can be given. And of course, in the after surgery, it will be compared with the placebo. That's we will discuss about Keynote 671 trial and the agent trial. And now I think that Checkmate 770 trial data are also there. Some data are there. And of course, adjuvant role means after surgery, means after surgery, we can of course give chemo, but after chemo, we can either give immunotherapy or we can just give the placebo. So that's what we will see in the IM Power 010 and Pearl Keynote 091 trial. So we'll discuss these trials which are where the immunotherapy has been combined with the surgery. So we'll discuss these trials one by one. So first we'll talk about the neoadjuvant trial. That's neoadjuvant nivolumab plus chemo in resectable lung cancer. That is Checkmate 816 trial. What they did, they have taken stage 1B to stage 3 NSCLC patients with a good performance status and without sensitizing EGFR mutation or ALK alteration. And they were randomized to receive Nivo plus chemo for 3 cycle versus chemo alone for 3 cycle. And of course, later on they were operated and option of adjuvant chemo and RT was there. Primary endpoints were pathological complete response and event-free survival. So what they found? They found that event-free survival was significantly better in the Nivo plus chemo. It was 31.6 months versus the 20.8 months in the chemo alone arm. The hazard ratio was 0.63 and it was significant. You can look at the curve, they are separate, and at 2 year, it is 63.8% EFS with the Nivo plus chemo versus 45.3% with the chemo alone. So it's significant. If you look at the subgroup analysis, then of course you can see all curves are towards the left. So almost all patients are getting benefited regardless of ECG performance, the baseline stage, histology, smoking status, or PD-L1 status, TMB, and type of platinum therapy. So all patients are getting benefited, and just 3 cycles are required. If you look at the pathological complete response, then in the Nivo plus chemo, it is almost 24% versus 2.2% with the chemo alone. And if you look at the overall survival, of course, the data is not yet mature, that is not reached, but at 2 year, it is almost the difference. You can see almost 12% difference is there. Now we'll talk about the perioperative trial when immuno is given before surgery and after surgery as well. So that is the keynote. First, we will discuss about perioperative pembrolizumab, and we'll talk about the keynote 671 trial. So what they did, the stage 2 to stage 3B patients were taken, and they were given either 4 cycle of chemo plus pembro or the chemo plus placebo, and thereafter they were operated, and they were continued for pembro for 13 cycle or placebo for 13 cycle. And the primary endpoint were 12 endpoint were there, the EFS as well as OS. So what they found? That they found that you can see event-free survival, it is at 24 months is 62.4% with the pembro versus 40.6% with the placebo, and hazard ratio of 0.58. So you can see it is significantly better with the pembro. So that forms the basis. If you look at the subgroup analysis, then of course you can see all curves towards the left. The pembro is better. Doesn't matter whether what is the PD-L1, what is patient's EGFR mutation status, what is the ALK mutation status, and what is the histology. So in all subsets, the pembro is better than placebo. If you look at the major pathological response, then it is 30.2% with the pembro versus 11% versus placebo. And if you look at the pathological complete response, then it is 18.1% with the pembro versus 4% with the placebo. In this form, they have also found that pathological complete response correlates with the event-free survival. The Of course, it is if patient achieves the pathological complete response, the event-free survival is better. So we can see that pathological complete response might be a surrogate for the event-free survival. Now, in the original trial, there was the carbon of the overall survival difference was not there. It is not significant. That is 18.9% with the pembro versus 77.6% with the placebo. But there was updated analysis was published, and what they shown that OS is significantly better with the pembro versus placebo. The hazard ratio was 0.72. So pembro becomes the first anti-PD-1 in therapy to demonstrate better survival when given as a perioperative versus preoperative chemo alone. The median OS was not reached in pembro versus 52.4 months with the placebo. The 3-year OS was 71.3% with the pembro versus 64% with the placebo. And of course, EFS is also better. 47.2 months with the pembro versus 18.3 months with the placebo. Of course, the grade 3 or more the adverse effect was 45% with pembro versus 37.8% with placebo. The discontinuation 20% and 9.3% and death in 1% versus 0.8%. So that forms the basis of the perioperative pembrolizumab, and that forms the basis of the FDA approval of this regimen. Now, there is another trial which, of course, there is OS data is not much mature. That's perioperative durvalumab was used for resectable NSCLC. That is the trial design looks like same. The in the stage 2A to 3B patients were taken 4-cycle durva versus durva plus chemo versus placebo plus chemo before surgery, and after surgery 12 cycle of durva versus placebo. And for primary endpoint were pathological complete response and event-free survival. So what they found that in the event-free survival was not reached in the durva arm versus 25.9% with the placebo arm. It is significant. The hazard ratio is 0.68, and you can see at 2 years 63.3% of EFS in durva versus 52.4% in the placebo arm. So you can see that event-free survival is better in this arm. And if you look at the pathological complete response, then it is 17.2% with durva versus 4.3% with the placebo. It is better. And if you look at the subgroup analysis, then all curves again towards left, so durva is better. So the perioperative arm, of course, we can see the OS data, we would like to wait for that. The similar trial was published, which I couldn't give the slide, that is JACMATE 77T, where they have used the perioperative nivolumab versus placebo. And what they found that is there is a better pathological complete response. It was, I think, around 25.3% in the Nivo versus 4.7% placebo. And event-free survival was not reached in the Nivo versus 18.4 months with the placebo. And of course, the hazard ratio was around 0.58. So that is a similar finding. Of course, there we don't have the OS data. We would like to wait for that. So that forms the basis of perioperative. Now we will talk about the adjuvant trial. So in the first, we will discuss adjuvant atezolizumab after chemo, that IMpower 010. They have taken the patient with the stage 1B to stage 3 patient, and they have taken chemo given after surgery. They have given 1 to 4 cycle of chemo, then randomized to receive either atezo for 416 cycle or bed supportive care. And of course, they were looking for a disease-free survival. So what they found that the disease survival is significantly better in the atezo arm versus placebo arm. It was almost not reached in the atezo versus 35.3 months of bed supportive care. The hazard ratio was 0.66, and if we look at 3-year data, then it is 60% versus 48.2%. So almost 12% improvement was there. That's what found the basis of disease-free survival. And if you look at the subgroup analysis, then of course there you might find that there are some lines are towards right, like if patient is current is smoker, or patient is ALK mutation is positive, or patient is taking cis plus JAM, then probably the benefit is not that great. But in the most of the subsets, you can see that atezo gives better disease-free survival. Now, if you look at the OS data, then of course the hazard ratio is only 0.81, the not reached versus 37.2 months. But later on, it was published that if you exclude the patient with the EGFR and ALK mutation, then what we found that there is the hazard ratio drops to 0.42. So if you find that there is no EGFR ALK mutation, then probably we would like to be inclined towards using this drug in this particular subject. Now we talk about the adjuvant Pembro, that's the Keynote-01 Pulse trial. That's what they found. They have taken stage 1B to stage 3A patient. And of course, 1 to 4 cycles of chemo were allowed. Then they were randomized to either receive 18 cycle of Pembro versus placebo. And what they found that, of course, in the disease-free survival, they found that in the overall population, it was 53.6 months in the Pembro versus 42 months in the placebo. The hazard ratio was 0.76. That's significant, but strange to us is that if they have selected the subset of PDL1 more than 50% by TPS, but there the hazard ratio was 0.82 only and the p-value was 0.14, not significant. So we don't know why this happened, but if you look at the subgroup analysis, then of course the patient is most of the lines are towards left, but if the patient is not receiving the adjuvant chemo or patient is having the squamous histology, then of course the hazard ratio is more than 1. Now, if you look at the OS data, then of course you can see the curves are overlapping. The hazard ratio is only 0.87 and p-value is 0.17. So there is no significant difference in the overall survival. So with the adjuvant Pembro, we can get disease better DFS, but not OS. Now, if we talk about the, of course, that's another modality of treatment is chemoradiation. But of course, there are chances of development of a tumor antigen release and adaptive immune response if the patient is given chemoradiation. But what happens that PD-L1 expression increases and there is immune evasion. So if you combine durvalumab with the chemoradiation, then of course that the immune suppression will be reversed and better tumor response can be achieved. So that forms the basis of PACIFIC trial. What is the PACIFIC trial? That is, they have given the durvalumab after chemotherapy in stage 3. So they have taken only stage 3 NSCLC in contrast to the previously discussed trial where predominantly they have taken stage 2 to stage 3 patient. And they have, after chemoradiation within 42 days, they have randomized to either receive durvalumab or placebo for 1 year. The primary endpoint were PFS and OS. And of course, what they found that, of course, the median PFS was 16.8 months with the Durva versus 5.6 months with the placebo. And if you look at the 18-month PFS, then it is 44.2% with the Durva versus 27.0% with the placebo. So the progression-free survival is better. If you look at the subgroup analysis, then again the all curves were left, whether what is the PD-L1 status, what is the tumor histology, whether the patient is EGFR mutated or not, doesn't matter. Durva is better. Of course, we don't have the LAURA data, but of course after that there might be some considerable. But as of now, even if the patient is EGFR positive, you can offer durvalumab to the patient. If you look at the anti-tumor response, then you can see objective response is 28.4% with Durva versus 16% with the placebo. If the benefit persists for 5 years, you can see that the updated 5-year analysis was there. It was 5-year OS is 42.9% with Durva versus 33.4% with the placebo, and the median OS is 47.5 months with Durva versus 29.1 months with the placebo. So that's on the specific. So what they found that they thought that patient should be eligible for PACIFIC regime more and more. But in the PACIFIC, the durvalumab is started 42 days after radiation. So they thought about that what we can do, if we start the Durva along with the chemo radiation, then whether the outcome will be better. So that formed the basis of PACIFIC 2 data, where they even at the starting of the chemo radiation, they have added durvalumab so that that Durva is given before patient could have the progress in the PACIFIC regime. So, but it didn't meet its primary endpoint of PFS, and so PACIFIC regimen remain standard of care. So, if the patient completes the chemo radiation, then within 42 days, if he is not progressing, he or she is not progressing, then he should offer durvalumab. That's the data. The starting durvalumab early at the initiation of chemo radiation doesn't give any additional advantage because there is no benefit in the primary progression-free survival. So that forms the PACIFIC data. Now, this is the data published in the last ESCO. So we are we have discussed a lot of immunotherapy drugs are available, and more than one approval is there in many subsets like neoadjuvant adjuvant setting. So this might be future that there should be some biomarker which will determine which immune checkpoint inhibitor should be used and whether immune checkpoint inhibitor should be combined with something or not. So what they did, that they have found, evaluated the NSCLC patient, and they found that not all patients are equally responding. So they found that there are some biomarkers like LAG3, TIG80, CTLA4, PD1, BTLA, V7, S3, OX40, etc. And these are more expressed, and PDL1, TIM3, ICOS, KLRD1, and VS. Yeah, these are less experts. So in those people who are not responding. So probably that might be future that we might have in future, we might be selecting immunotherapy drugs based on the biomarker expression, and we might be combining either two immunotherapy drugs, like combining with the PD1 or PDL1 inhibitor with the CTLA4 inhibitor. So based on these biomarkers. Another point which they have discussed in the last ESCO, that's they have found that there might be, in future, we might be testing the minimal residual disease, and based on that we might be offering patient immunotherapy, and that form probably there are some trials are also going on for probably from which might be in future, that is Mermaid trial. So probably that will guide immunotherapy for those patients who are MRD positive after treatment. Another, of course, we know about the pathological complete response. So in future, we might be offering these kind of regimens for those patients who are not achieving pathological complete response. So to end, I would like to say that both neoadjuvant, that is nivolumab, and adjuvant, that is atezo and pembro, improve outcome, and these are FDA approved drugs. Neoadjuvant may give more benefit with a short duration. Of course, you are supposed to give only 3 cycles. So if you want to choose between neoadjuvant versus adjuvant, then probably you might be inclined towards the neoadjuvant. The perioperative, that is pembro, in Keynote 671, and durva in agent trial also improve outcome. Of course, the advantage versus neoadjuvant and adjuvant require longer follow-up. Recent data shows that perioperative pembro improves overall survival versus preoperative chemo. Of course, that forms the basis of its FDA approval. Durva, given administered post chemo radiation, improves outcome and is FDA approved, and its overall survival benefit persists at 5 years. Starting Durva along with the chemo radiation doesn't offer any advantage that is specific to regime. We couldn't improve the PFS. And biomarker guided approach may determine optimal selection of immune checkpoint inhibitors and their combination in management of NSCLC patients in future. Thank you.
Thank you so much, sir, for your excellent talk. For the next talk, I would like to invite Dr. A.P. Dubey, sir. Sir is Senior Consultant and Unit Head, Medical Oncology and Hemato-Oncology, Metro Hospital, Delhi. This session is sponsored by AstraZeneca. Sir will talk on optimal treatment in advanced EGFR and NSCLC. Over to you, sir.
I hope my slides are audible.
Yes, sir,
My
it's
slides are visible
visible.
and I am audible. Sorry. So, at the outset, I would like to thank the organizers for giving me this opportunity. And nonetheless, Astra too was always providing me the opportunity to speak on such a lovely molecule that is osimertinib. So, my talk will be optimizing treatment in the advanced EGFR mutated lung cancer. As we all know that understanding the molecular pathways which drive malignancy has led to development of targeted therapies. Is the most commonly observed driver mutation, which can be seen in around 50% of Asian, as well as around 10 to 20% of Western population. And among Indian patients, it is seen among around 20 to 40% in multiple studies. What actually EGFR mutation is, it is actually a mutation located in the tyrosine kinase domain, which results in the constitutive active pathway leading to continued tumor proliferation, metastasis, angiogenesis, and etc. etc. So we have to target these the most commonly observed driver mutation, we have first generation, second generation, and third generation anti-EGFR tyrosine kinase inhibitors, which are quite different from each other. We have first generation TKI, namely erlotinib and gefitinib, second generation afatinib and dacomitinib, and the third generation we have a sole claimer, which is osimertinib. They are different in their activity range and the type of binding to the EGFR kinase domain. So, for example, first generation TKI, they bind reversibly and to both the wild type and mutant EGFR, but they are inactive to T790M mutant, which is the most common cause of resistance when patient is put on first or second line TKI. Whereas second generation and third generation, it irreversibly bind to the EGFR kinase domain. But the difference between the second and third generation is that it is the second generation TKIs are pan EGFR. They work against pan EGFR, whereas third generation is EGFR mutant specific, which makes it quite tolerable, the best safety and toxicity profile. So what is the evidence? We have the FLORA, a randomized double-blind phase 3 study, which has assessed or addressed the safety and the efficacy of osimertinib versus standard of care, that is first generation EGFR TKI, as the first-line treatment with locally advanced metastatic EGFR-mutated non-small cell lung cancer. Osimertinib is structurally different, as I have said, that because it binds irreversibly, there is a covalent irreversible bond with the tyrosine kinase domain. And secondly, it is EGFR mutant specific, as when in contrast to second generation, which is pan EGFR inhibitor, leading to lots of toxicity with the second generation TKI, whereas the third generation TKI is quite well tolerable. Osimertinib, apart from EGFR mutant specific, it also acts on EGFR T790M, which is the most common cause of resistance to the first and second generation TKI, which is seen around in up to 60% of the patient over the duration of 10 to 16 months when patient is put on first or second generation TKI. So that also too is addressed by osimertinib. And also amongst all TKIs, it has one of the best blood-brain barrier penetration capacity, which is seen in both human as well as preclinical models. This is the FLORA study design where the patients with metastatic or locally advanced non-small cell lung cancer with most common EGFR mutation like exon 19 del, which is seen around 45% patients, and L858R, which is seen around 40% of patients with stable CNS metastasis. If it was, they were also allowed. They were randomized 1:1 to osimertinib 80 milligram daily or to vis-a-vis first generation EGFR TKI, either gefitinib or erlotinib. The primary endpoint was progression-free survival, but there was multiple secondary endpoint where the overall survival, objective response rate, duration of response, disease control, and depth of response. So osimertinib actually concluded with significant improvement in its primary endpoint, that is progression-free survival. You can see the beautiful separation of curves right from the beginning, giving the median progression-free survival of 18.9 versus 10.2 months with the first generation TKI. The very fantastic hazard ratio of 0.46. That means 54% reduced risk of progression, that you can see that very significant p-value. Now coming to the forest plot, and you can see there's none of the subgroup is which has not received benefit from osimertinib, although the magnitude of benefit may differ, but all the subgroup, irrespective of age, sex, race, smoking history, CNS metastasis, progression, performance status, they are actually benefiting from this third generation TKI. Now coming to overall survival, although the patients were allowed to cross over provided they have progressed from first or second generation TKI in the comparator arm, still FLORA is the only study where a third generation TKI has shown significant improvement in median overall survival. As you can see that the overall survival with osimertinib is 38.6 with the vis-a-vis 31.8 months with the first generation TKI. That too, despite the crossover with a hazard ratio of 0.79. Now, this is also one of the commendable characteristic of the patient who were at osimertinib, that around all near about 1/3 of the patient were receiving osimertinib at the end of 3 years, whereas you can see that only about 5% of the patient were receiving the first generation TKI till that time. Now the time to first subsequent treatment, that whatever patient has taken treatment after progressing on the treatment which the patient was randomized to, the number of events occurring in the osimertinib arm were 194 vis-a-vis 242 with the comparator first generation EGFR TKI. With the hazard ratio, you can see that 0.78. The probability of being progression free was quite high, was with significantly high with osimertinib as compared to the first generation TKI. Now coming to the efficacy of osimertinib across all the clinical subgroups, as we have seen that PFS was the primary endpoint and the OS was the secondary endpoint, and you can see that PFS, all the subgroups are getting benefit with the osimertinib. Whereas you can also see overall survival also, there are majority of subgroups are receiving benefit despite the crossover, although the magnitude of benefit may differ among the subgroups. So osimertinib PFS benefit was remarkably and consistently same across all the subgroup, demonstrating its superior benefit. Although OS subgroup, every subgroup did not show the overall survival benefit, but most of the subgroups have shown overall survival benefit with the positive benefit in the favor of osimertinib, although the magnitude did vary. This is the consistent with PFS data in which all the subgroups favored osimertinib. So why do we think that osimertinib should be the first line upfront therapy for the patient with metastatic non-small cell lung cancer? So this is very important thing which has come up in these slides. That is, are only 30% of the patients are eligible for osimertinib if they are being given as a subsequent line. It means when they are not offered the osimertinib in the upfront setting. Why it is so? That because only 50% patients who are alive and who have progressed on the first line TKI will get an accurate test which will result in a T790M positive. And why it is so? Because around 70% patients will, 60 to 70% will only have the accurate T790M. Why it is so? Because either the patients are not fit for tissue biopsy, or patient have insufficient tissue from tissue biopsy, or the plasma test, which is not a standard, but still it is being taken through because it is quite sensitive, but there can be false negativity in plasma test. Generally, we then follow it by biopsy or the test. So only 70 to 77% of the EGFR mutant patient among them will receive any second line therapy. So this is if the 10 patients starts on gefitinib, erlotinib or afatinib, or means first or second generation TKI, 30% will not receive the subsequent line of treatment. Only 70 to 77% will receive the subsequent line of treatment or the second line of the treatment. Among that, only 70% of that 70% will get a valid T790M result, and others will either not be fit for tissue biopsy or will not have adequate tumor or will have false negative plasma test. And among those who have the valid T790M result, only 50% will have the test which is positive and will go ahead with osimertinib, whereas rest will have T790M negative and cannot be put on osimertinib. So it means that out of those 10, only 3 will be eligible for osimertinib. So that means only 30% of patients become eligible for such a great drug if it is not offered as upfront treatment. So this is evident in multiple studies, and the main reason is that most of the patients are not fit for biopsy, or the plasma test is negative, or some patients refuse. Various clinical trials have actually analyzed and concluded that in AURA3 study, only 79.2% of the patients screened had a valid EGFR mutation test. Only 79. So means around 20% couldn't get that valid testing. Whereas other studies, either around 20 to 30% of the patients were not fit for biopsy, or there was inadequate tumor tissue for to be checked for T790M mutation. So ultimately to conclude is that only 30% of the patient will receive second line osimertinib or will have eligibility for the second line or subsequent line osimertinib if they are not offered with the osimertinib in the front line. Now you can see that if 100% of the patient on our started on osimertinib, there will be around 22% will still remain in the treatment and 78% will be discontinued, whether it is progression or death or whatsoever reason. Out of that 31%, in total 31% of the total 100% will not receive any subsequent therapy. Only 48% will receive the second line therapy. It is case where the osimertinib is getting started. So around 50% of the patient will receive certain therapy. Now we see the comparator arm. The patient is started on first line EGFR TKI. Only 5% will remain on the treatment. 95% will discontinue. And then 30% will have no subsequent therapy and 65% will receive second line therapy. And in these second line therapy, what patient you can see that around 50% of them will get osimertinib and rest will get other EGFR TKI other than osimertinib or cytotoxic chemotherapy. So they are not getting the benefit of osimertinib. There are multiple studies that around 1/3 of the patients do not receive a second line because either progression or they go on palliative treatment or patient has a mortality. These are the various trials which have shown that not all patients who have put on first or second line TKI receive the subsequent line of treatment. So that which conclude with the statement that once first hit should be the hard hit and the best therapy should be offered to the patient. Now, in real world study with EGFR mutation, non-small cell lung cancer, the risk of not receiving second line therapy is very high. Here you can see that 130 to 140 patients, 130 patients were treated with first line EGFR TKI and 112 patients were candidate for second line therapy. 30% of the patients, 34 out of 112 did not receive any second line therapy. Maybe because of patient refusal, poor performance status, fast progression, or very poor performance status that precludes subsequent treatment. There's multiple real-world studies across multiple countries which has confirmed in the clinical practice that 1/3 of the fewer patients receive second-line osimertinib. So the drug which could be offered in the first line upfront with the highest efficacy as compared to the first and second generation TKI, if not offered at the right time, then as a subsequent line, only 1/3 of the patient will receive this drug. So head-to-head clinical trials of EGFR TKIs are consistent with the real-world data. Not all patients receive the second-line osimertinib. Here you can see that Archer study, only 10% of the patients are receiving the third-generation TKI on progression. Now, if we talk about treatment sequencing, although what is the proper sequence is not known, but if we dramatize the sequencing with the osimertinib, either the upfront or maybe on the subsequent line, you can see the benefit. As you can see also, we have observed in FLORA trial also, the overall survival is higher in the patients who have received upfront osimertinib rather than patients who have received frontline, then getting crossover to the subsequent line, that is osimertinib on the second line therapy. And you can see that first line osimertinib will remain the best because it is giving the best benefit of 18.9 months, whereas the second line it will give 10.1 months and followed by chemotherapy. Whereas if it is the patient is started with the first generation TKI, only 1/3 of the patient will end up receiving the subsequent or the third generation TKI osimertinib. So the message which we can draw from this slide set or the multiple studies which have shown that the FLORA trial was the first study which has demonstrated an EGFR TKI to demonstrate a very clinically meaningful and significant progression-free survival, and which is getting translated to the overall survival benefit also, despite the crossover. Osimertinib is the only EGFR TKI which has shown the statistically significant intracranial efficacy, means irrespective of the brain metastasis, it is showing its efficacy. It is well-tolerable drug because it is EGFR mutant specific, in contrast to the pan-EGFR inhibitor second-generation TKI, where the dose reduction or dose interruption was seen in around 2/3 of the patients. Sequencing cannot be considered the best strategy, as almost 70% patients are not eligible to receive osimertinib in the second line. As we can see that the overall survival remains the best if the patient is receiving the first line osimertinib. So these are the NCCN guideline recommendation for osimertinib in patients who have common EGFR mutation, that is EGFR 19DIL or exon 21-858R, which accounts for around 85 to 90% of the mutations. There you can see that the category 1 remains osimertinib. So thanks for the patient hearing, and thanks to organizers and Astra for giving me this opportunity.
Thank you so much, sir, for your excellent talk. For the closing remarks and vote of thanks, now I'd like to invite Dr. Tejinder Singh, sir. Sir is Chief Health Director and HOD Oncology, Northern Railway Central Hospital, Delhi. Over to you, sir, for the closing remarks.
Thanks. It has been a great pleasure being with all of you today in this successful academic feast. My special gratitude to the speakers, Dr. Shyam Agrawal, Dr. Aparna Dhar, Dr. Kanika, Dr. Shubham, Dr. Ankur, Dr. Mohit, and Dr. A.P. Dubey for giving the valuable time and the inputs. I would like to thank the organizer, Dr. Sumant Gupta, for organizing such a nice meeting. I would also like to thank the Horizon team and the academic partners for today's program, the Astra, Intas, Zydus, and Ecailio. And as we are now closing the meet, thanks everyone for attending, and goodbye and enjoy the evening. Thanks.
Thank you, sir.